Perfect. Hey guys, we're just gonna give everyone a minute to join us for our office hours. Can't believe it's already February. I feel like the New Year's was yesterday, but thank you everyone. Again, we just wrapped up our Thyroid Awareness Month campaign. Super exciting. So thank you so much for everybody joining. And if you didn't get to attend any of our webinars, please reach out. We have a bunch of educational webinars that we did with a bunch of our providers. But in the meantime, why don't we go ahead and get started? My name is Alex Ruiz. I am the Director of Marketing here at Paloma Health. For those that don't know who we are an online medical practice, meaning that we are a fully functional medical team that can provide care virtually, so meaning in the comfort of your own home. Providers like Dr Cunningham here today, who is our special guest, is one of those providers that you can see. And what that means is that we can provide care, so we can request labs, we can obviously fulfill any medication needs, we consider all medication options. Our providers really pride themselves on doing a lot of holistic practices. So we look at not only obviously your labs, but how are you feeling? What are your symptoms? We also take into consideration nutrition and lifestyle, because that all impacts so much of your care and your treatment plan. We also have tons of resources on our mobile app, which is completely free, and our website that you can go to. Plenty of workouts, blogs, recipes, resources, and all the things, meditations, sleep guides, you name it, we probably have it for you. So without further ado, I'm going to go ahead and toss it off to Dr. Cunningham, and he's going to be doing our office hours today, where we get to ask him a bunch of questions that you have. So without further ado, Dr. Cunningham.
Hello, thank you, Alex. Thanks everybody for joining. I'm Dr. Cunningham. I'm one of the docs here that I've been here over 4 years, I think now. My background is in family medicine, and I'm board certified in integrative medicine as well, and have been doing a lot of dedicated thyroid care work with Paloma for a few years, as I mentioned. So I'm happy to join you, and I look forward to answering your questions today. Okay, so I'm going to jump right in. So the first question is about T3 only treatment for hypothyroidism. This one doesn't really come up that often, but it does periodically, and there probably isn't real obvious answers to this if somebody was just to search for it. I'll give like a quick kind of discussion of T4 and T3. So T4 and T3, the major difference is the number tells us how many iodine atoms are on this hormone molecule. T4 is levothyroxine or Synthroid or Tirosint, or it's kind of considered the foundation of thyroid hormone replacement per usual kind of guidelines. Most of what our thyroids make is T4. But T3 is an active form of thyroid hormone. One distinction between the two is that T4 is very long acting. It's kind of a pro-hormone that our body converts into T3, whereas T3 is short acting. So I think historically there probably was some use of T3 as like the primary treatment for hypothyroidism, but it is not typically done because it, well, as I mentioned, it's short acting. There's not a pharmaceutical sustained release T3 on the market. And it's kind of considered maybe like if you're just putting only the activated form into the system, then that's kind of a sort of bioidentical, or not really like the way that we like to mimic natural physiology. So we do use T3 as an amendment to thyroid hormone replacement sometimes, but my preference, and I think all of the preference of the docs here and kind of universally, I think in most of the world, is to use mostly T4 and then add some T3 as needed, because then you're providing sort of this really long acting pro hormone that our body can convert into T3 as needed, and then use T3 sort of as a supplement on top of that. So I personally don't think that T3 only treatment is kind of the best call for most people. I have known a couple people to be on very low doses of T3 only. Those are very atypical cases and not something that we really see or advocate for most of the time. All right, so another question is thoughts about low cortisol and adrenal fatigue, and is this a legitimate medical condition? How does it affect the thyroid? So within sort of conventional diagnostic names of things, adrenal fatigue isn't really a recognized medical condition. Adrenal insufficiency that's a different condition altogether. That's not very common. I would say disruption of people's cortisol rhythms, though, is a common phenomenon that's impacted by stress and lack of sleep and disrupted circadian rhythms and things like that. I do think that, so that's usually when somebody calls something adrenal fatigue, what they're referring to is disruption of rhythms of cortisol. Cortisol is a stress hormone produced by the adrenal glands. And the normal rhythm of cortisol is to go up in the morning and then kind of gradually de-escalate over the course of the day. There are different ways to measure cortisol. You can measure cortisol in a blood test. What this is about, this question in particular, is about saliva cortisol testing, which gives us an idea. So there are some companies that offer this saliva cortisol test where you maybe do like a saliva level here, a saliva level here, another one here, and another one here 4 times over the course of the day, which gives a much better idea of how the rhythm looks instead of just a single spot cortisol. And, apart from lifestyle measures to try to help people kind of resume natural cortisol rhythms, like stress reduction and good sleep and things like that, historically, this is where tonics or adaptogens in the botanical medicine realm would be used to help kind of modulate and shift the body's physiology back towards normal cortisol rhythms. So I do find that this goes, is often associated with people's hypothyroidism. It's typically a transient thing that, their rhythms get disrupted in acute stress, but some people can get disrupted for long periods of time. And sometimes we can help people sort of support better thyroid function by supporting adrenal function using these kind of herbs like adaptogens, and there's some other supplements that can help with that. So I don't order saliva cortisol testing most of the time. A lot of times I'll just recommend people take adaptogens, but I think that information can be useful. The next question is about ashwagandha. So ashwagandha is an adaptogen. It's a plant that's native to the Asian subcontinent, South Asia, India, has been used for thousands of years in Ayurvedic medicine. There's pretty strong research that ashwagandha does modulate cortisol rhythms, so it's a popular adaptogen. I don't actually know anything about ashwagandha and predisposing people for breast cysts, so it could be a blind spot that I don't know about, but I'm not familiar with a question. The question that the person asked is thoughts on ashwagandha for hypothyroidism and predisposition towards breast cysts, and and I think their question is that related to hormone replacement therapy? And another question about stopping T4 and T4 medication with use of ashwagandha. So I'll just kind of give a high level, I think ashwagandha is a pretty good ally for a lot of people that have hypothyroidism that also feel, stress or difficulty sleeping. It's a pretty safe, well-tolerated adaptogen. It's widely available. I think it really, grew in popularity in the last few years. It's not commonly adulterated. I feel like it's not a supplement that necessarily you have to keep it localized to like 1 or 2 good brands. I think there are several good makers of ashwagandha supplements. And I pretty universally tell folks that I see that if they want to take ashwagandha in conjunction with their thyroid medicines, I don't see a problem. But I think sometimes people have seen something about ashwagandha and possibly it being a nightshade plant, which nightshades impact some people with autoimmune diseases negatively. So I like ashwagandha, and I like to use it with thyroid meds, but I don't know about associations with breast cysts. And I think it can be taken in conjunction with thyroid meds. And the next question is about things that we can do to lower thyroid peroxidase or TPO antibodies. And what's the expected time period to see when, like, what do we expect to see over what time period would interventions help lower TPO? And then also kind of what's the best food plan to eat to see progress? Okay, this is a complicated one. And I talk about it with people that see me pretty frequently. So TPO is thyroid peroxidase. Most people that have Hashimoto's have elevated TPO antibodies. Some people that have Graves' disease, which is a cause of hyperthyroidism, also have elevated TPO antibodies. So it's an auto antibody indicating there's an autoimmune activity at play. People's TPO antibodies can be really alarming when you see lab reports. The normal range is usually somewhere like 0 to 35 or 60. Some people's are well over 1,000. And there are a lot of different things that impact these antibodies. So anything that impacts the immune system could be really considered as something that impacts TPO antibody levels. That would include genetic predispositions, triggers like infections, dietary intolerances, which might disrupt the gut immune system. There are some medications that impact it sometimes. The question here is, over what time period would we expect to see lowering of TPO antibodies with a lifestyle or other intervention? So one thing I'll say about that is some people make really beneficial lifestyle or supplemental parts of their thyroid treatment plan and feel much better, but don't have reduction of their TPO antibody levels. Sometimes people's TPO antibody levels just drop despite them not doing anything to consciously try to lower them. So that speaks to the complexity. There's really not like a do this thing or this thing and your antibodies will go down, because it's going to be different for everybody. I think in regards to time periods that we do see progression of lowering TPO antibodies, it usually doesn't happen abruptly. It usually does happen more in a 6+ month time window. I typically encourage people not to get too attached to the idea of lowering their TPO antibody levels, because as I said, I've seen countless cases where somebody feels much better after making, say, a dietary modification that has improved their symptoms. And then they may be frustrated that their TPO antibody levels don't lower, because we're trained like that to, want to see numerical progress for things. But the labs don't always tell the whole story there. So if you don't see your TPO antibody levels dropping, don't get too concerned about it. Stay the course. Keep doing what will help you feel better. So I see it as like maybe a benefit when people's antibody levels start to lower, but I don't personally feel like there is sort of failure of the treatment plan or anything like that if it doesn't come down. Sort of an attached question of this is about the best food plan for seeing progress. And there are a number of, I think the easiest way to encapsulate that, in my opinion, would be to say like an anti-inflammatory diet, which would be rich in brightly colored, nutrient-dense foods, kind of Mediterranean style diet, low in processed foods. If you want to be more kind of methodical past doing an anti-inflammatory dietary plan. There is the possibility of looking at gluten's impact on your body, because gluten intolerance is more common among people who have Hashimoto's and other autoimmune conditions. There's AIP diet, which we see a lot of people really improve from. AIP is relatively restrictive, so it's not sustainable for a lot of people to do for a long period of time. So if you want to start with AIP and then gradually start to reintroduce things and liberalize your diet so that you can avoid things that may be harming you, but not avoid too many things, then that's kind of the best way to do it. So there's not a best food plan for everybody. We have a registered dietitian who can help us decide, where we might want to start. But a lot of times I recommend people give a trial of gluten-free for a bit and see how that goes. And then if that doesn't make much difference, we look at other strategies. All right, next question is about T4 and T3 conversion. So the question is, what tests need to be done to see if I'm converting my T3 and T4 medications? So T4 is, as I said, the foundation of most thyroid hormone replacement plans. Some people, there are differences in how well people convert T4 to the active form, which is T3. The reasons for that can be other health problems, gut microbiome, variations by person. And then there are also some genetics behind the enzyme system that converts T4 to T3. This is a rapidly evolving, I think, story. We don't know the answer to why some people convert T4 to T3 better than others completely. And it's not really a super easy thing to measure. Sometimes when people get a thyroid panel like Paloma offers measured, and they have a robustly normal T4 level, but a low T3 level, then that would be an insinuation that they may not be converting T4 to T3 well. But otherwise, there are kind of proxy tests that give us a little bit of information, but they don't really tell us the whole story. I've had some people who have gotten 23andMe tests done and found out that they do have genetic mutations in the deiodinase system, which converts T4 to T3. That's not really a test that's widely available through regular labs to look at the deiodinase system, because I think thyroid researchers are still trying to determine the clinical utility of that. There's a reverse T3 test, which sometimes will give us a little bit more information if somebody's on, say, too much thyroid hormone, or if a lot of their T4 is getting routed to reverse T3 instead of T3. But again, this is more of a got to look at the whole picture to decide, yes, it seems like you're converting or not. And also how are somebody's symptoms? Because the labs aren't the only reason for deciding whether or not we want to use some T3 in addition to T4. Sometimes it can be more based on how somebody's symptoms are. This next question is a really interesting one, I think. It's about LDN, which is low dose naltrexone. This is kind of a immunomodulatory off-label medicine that has to be received from a compounding pharmacy by prescription. LDN has some enthusiasm among certain doctors for uses in autoimmune conditions and some other things like impaired gut motility, and there's a bunch of off-label uses of LDN. There are a lot of doctors who don't prescribe LDN because they don't feel like there is really enough robust research to recommend it, or they think maybe that there's not going to be a lot of benefit. So not all the doctors that work here do use LDN. I do prescribe LDN, not to everybody, but to some people. And this question about when should LDN be prescribed might vary depending on who you ask. So in my opinion, I might use it if I feel like somebody's made a lot of sort of beneficial lifestyle choices and has really still a lot of ongoing symptoms, particularly if they have a predisposition to other autoimmune conditions, if they have a lot of connective tissue, joint, muscular pain. I've sometimes seen people with Hashimoto's thyroiditis who take LDN, which has an impact on the immune system through endorphins. And I've seen some people respond really fabulously to it. Like they're like, wow, all these symptoms have really improved. Sometimes people's antibody levels will decrease after they're on it for a while. Sometimes they won't. Some people notice nothing. Some people feel great on it. It's used outside of thyroid medicine, as I described too. I know people have rheumatoid arthritis that take it. So it's not universally available to people, but I do kind of, see some people as being a better candidate for it. So I think if it's something that you want to inquire about, ask your doctor. Like I said, not everybody is comfortable prescribing it. We're all still learning about how to use it. All right. Next question is about compounded and non-compounded Armour thyroid medications. And, or this would be more about compounded desiccated medication. So somebody said that they recently started taking compounded medicines and feel better, but the cost is a lot higher. So Armour and NP thyroid and Adthyza, those are like kind of the primary brands of desiccated porcine thyroid. Unfortunately, many of those pre-formulated ones, like they don't always come in the right dose that somebody needs. For example, if somebody's proper Armour thyroid dose is 75 milligrams, Armour comes in 30, 60, 90, 15. They may have to buy 2 separate prescriptions in order to get that 75. That's a scenario where somebody might be getting a compounded thyroid medicine. I think the main reason that I see people take compounded thyroid medicines here, there are 2. One is in order to find a dose that's not otherwise easily sort of available. The other would be related to fillers that are found in thyroid med. So if you get a compounded medicine, you can ask the pharmacy to use whichever fillers they have available that they can put together to make the medicine. So some people take a compounded desiccated thyroid medicine in order to avoid certain fillers that they may be sensitive to. The cost can be higher because there is like a person in a pharmacy that's, sitting at a lab bench and compounding that medicine. So there's more labor involved. This kind of comes down to like, a risk cost calculation. Somebody feels say 30% better and they're paying 10% more, then it's kind of like, well, maybe the additional cost is worth it. So I think whenever you arrive on a medication plan that feels like it works really well for you, then sometimes it's best not to mess with it. And then you might look around to find out if there is a different compounding pharmacy that could provide you that same thing for less expensive, or buying it in a larger number of pills to reduce cost and labor. But the main differences between compounded and non-compounded desiccated meds are fillers and dose availabilities. Alex, do you want to give me another question? The next one that I see here is about parasites and Hashimoto's, which I don't think I have a great answer to that would be very clear and probably informative for the person asking that. The next one is about thyroid glandulars and adrenal glandulars to help regulate our thyroid. So, okay, glandulars are I guess, this would be like a medicine made from an animal gland, like an animal thyroid gland or an animal adrenal gland. Um, Desiccated thyroid meds like Armour and NP thyroid, those are kind of glandular meds, but there are also a whole bunch of glandular thyroid and adrenal support supplements, which may or may not include hormones that are available on the market. I tend not to like to use these and recommend against them for people who are taking thyroid um, hormone. And the reason is because the glandulars are kind of unregulated, and a lot of times the companies that make those don't test them or define how much hormone is actually present in that. So it can make dosing really tricky. If somebody's taking a glandular because they want to get the extra sort of supportive kind of broad spectrum components that are in the thyroid, but then they're also taking thyroid medicine together, then they may be inadvertently getting extra thyroid hormone in the glandular supplement. So it can make testing and dose titration more challenging. And because there is such a sort of discrepancy across glandular brands and what's in them, I tend to recommend against them. If somebody wants to be on a thyroid glandular, I'd rather put them on a sort of regulated thyroid glandular medication, like one of the desiccated ones. I know we're kind of getting low on time, so I'm going to go to the next question, which is about arthritis and joint pain and Hashimoto's disease. So kind of a chicken and egg thing here. I mean, a lot of people that have Hashimoto's do have, systemic body discomfort, even when their thyroid hormone levels have been normalized with medicines. And really, that's because Hashimoto's is a systemic condition that just has the thyroid as its main victim. But if somebody has an autoimmune cause of their thyroid condition, then that can also cause symptoms that don't remit just with thyroid hormone supplementation. And I do see this pretty frequently. And there are a number of reasons for it, but I think the common denominator in a lot of it is that so much of our immune system is in our gut. So if somebody is, for example, chronically subjecting their gut to something that is, inflaming their gut, causing disruption of the immune system there, then they may, there's just like there's a gut brain axis and a gut thyroid axis, there's a gut skin axis, a gut joint axis. There are ways that disruption in the gut impacts immunity and sort of other tissues that receive blood flow and, immune cells from our body. So I think some people really benefit from just getting their dose nailed down and their arthritis gets better. I saw somebody today who, when they're on a certain dose that's a little more aggressive, but still in normal range, their joints feel much better. But if their TSH is treated only to, say, 3 or something like that, maybe they're still in pain. But that's a condition, that's a situation where I personally sometimes might use low dose naltrexone to see if it helps with the pain. All right, last question here. And all right, so this is about somebody who had their thyroid removed and had goiters, very large goiters. Let's see, it looks like golf ball size goiter a few years ago. The biopsy had showed that the person had Hashimoto's and probably had it for a long time, but was never treated. Let's see. They were never treated for it, but they had been hyperthyroid for 15 years prior. Okay. So their question really is, after they had their thyroid removed and it showed that it looked like it had Hashimoto's, since the thyroid is gone, do they still have Hashimoto's with their antibody level being undetectable? Yeah, I mean, that is a tricky question. I would say if the antibody levels have gone to 0 and the thyroid is gone, then there might still be a setup for some autoimmunity there, but they don't have Hashimoto's thyroiditis. So I guess the implication would be, do I need to be kind of thinking of myself as having an autoimmune condition and trying to treat that if, you know, the organ that was being damaged by it is gone, and if my antibodies are less than 1? I don't know the answer to that question, to be honest. Definition of Hashimoto's can be kind of slippery. I mean, some people can have normal antibody levels, and then a thyroid ultrasound will demonstrate that it looks like Hashimoto's. So yeah, sorry, I don't have a real yes or no on that, but I think that the antibodies have gone to 0 is probably a good indicator.
Awesome. Thank you so much, Dr. Cunningham. All right, guys, that wraps up our February office hours. Again, as I mentioned earlier, we are a full-line online medical practice, so you can see providers like Dr. Cunningham. If you would like to make an appointment with him, you do have to become a member. So you just sign up on our website, palomahealth.com. You fill in an intake form, and depending on where you live in your state and availability, you can book an appointment with Dr. Cunningham. Until next time, we do have another office hours next month. We do one every single month with a new provider every month. So please join us if we didn't get to answer your questions. We also have our community that you can bounce questions with other patients and members and kind of just get a feel of, you know, what's been going on, and it kind of helps support each other in that way. So again, thank you so much for joining us. Dr. Cunningham, thank you so much for being our